Hello and good evening. I'm Michael Stewart. I'm also the Chief Medical Officer of our physician organization, our practice plan, and we're one of the sponsors of tonight's event and some other health talks that will be starting later on. These talks are designed to allow physicians from Weill Cornell Medicine to speak to you directly about some topics that are dramatically changing the way healthcare is delivered today and in the future. Weill Cornell Medical College has been proud to be part of the Upper East Side since the late 1920s, and we're affiliated, of course, with New York Presbyterian Hospital, the top hospital in New York, for 16 years running. And our physicians have many offices here in the Upper East Side, including a primary care practice very close by on 85th Street. Tonight's topic is digital health. And digital has changed our lives in many ways. Many of you were on your phones just now, and so we're all, the way we use our phones and computers has really changed our lives, and it has the potential to change healthcare as well. So we're going to have our expert panel talk about some of those things and what we know and what we don't know and what we think might happen. At Weill Cornell and at New York Presbyterian, we've been actively exploring ways we can better integrate digital health into our care model for a variety of reasons that you'll hear about. And we also have a portal, a patient portal, as part of our electronic medical record, and we call that Weill Cornell Connect, that allows patients to connect electronically to their own health records and to their doctors. We're also partnering with our hospital and researchers to implement programs that allow patients to actually get some of their care, not just to access their records, but to actually potentially get some of their care remotely, where that's appropriate through virtual visits. And so we're hoping to stay in front of digital health and use it in appropriate ways to help healthcare delivery. And so I'll now turn the program over to Jonathan LaMantia, who is going to introduce the rest of the speakers. Thank you.
Thank you, Michael. Good evening. My name's Jonathan LaMantia. I'm a healthcare reporter with Crain's New York Business. We're going to hear from a number of Weill Cornell physicians and researchers about how digital health is transforming patient care. Our panel members include Jessica Ancker, an associate professor of healthcare policy at Weill Cornell Medicine, Chong, site chief of neurology and director of the Stroke Center at New York Presbyterian Lower Manhattan Hospital, Curtis Cole, chief information officer at Weill Cornell Medicine, Deborah Estrinm, a professor of computer science at Cornell Tech and a professor of public health at Weill Cornell Medical College, Megan Olden, a clinical assistant professor in psychology in psychiatry at Weill Cornell Medicine, and Adam Stracher, director of the primary care division of the Weill Cornell Physician Organization. I'm going to start off with a question for Adam. How do you see digital health transforming primary care and specialty care at Weill Cornell?
So I think obviously digital health is a very broad topic, but I think two big ways. One is the obvious, which is the electronic health record, which houses all of our medical records for patients and helps us transfer care from primary care physicians to specialists to hospital and back, and allows us to have that sort of seamless transition of care and seamless transition of information. So I think that's one way, and that's obviously been around for for a bunch of years, depending on where you are. But I think we've really done that so that we have seamless care across our entire institution. And then I think the other area that we'll talk a little bit more about, which is, again, when people think of digital health or telehealth, I think the telemedicine arena around where patients will be able to get care from their physicians either during the day or after hours remotely when it's appropriate. So to interact with their primary care physician or their specialist either for initial care, urgent care, follow-up care, whatever it is, whatever's appropriate, I think that will be something that will definitely be transforming the way we're providing the care.
So Jessica, the patient portal is the way a lot of us interact digitally with our hospitals and doctors. So who are the most likely users of the patient portal based on the research that you've done?
So I think it's important to remember that the patient portal is very recent. Just in the last few years, really, now medical centers make available a website where you can log on and you can see your own medical records. So we've always had the right to look at our medical records, but who would go through the effort of finding a photocopy of your entire medical chart? But now that it's electronically available, they're very popular. People really like seeing that. We certainly see differences in who's most likely to use it. People who have more medical conditions are, in fact, more likely to use it, and I think that makes sense. If you're perfectly healthy, why would you bother doing that? And then, the flip side is we see some disparities as well. there are a significant number of Americans who have very limited literacy skills. We've got probably about 14% of the population who really has trouble reading very basic information. And those are the people who are really not going to be accessing these technologies. The good news is that we actually do see over the years, as these technologies become more accepted and more easily usable, we actually see those disparities getting narrower and narrower. More people who previously maybe were a little intimidated by computers or didn't really know how to use these technologies, we're seeing more and more of them now taking advantage of those.
And are there certain things, within the patient portal that you've kind of identified as, not really being helpful, turning people off and getting, causing people to kind of disengage with their own health?
One problem with any medical information is that it's really full of jargon. And I'm sure everyone has had this situation where you sit there in the doctor's office and you hear these words flowing over you. Like, what was just told to me? I don't remember. And we see that as well when people log in and you see your medical records. If you encounter unfamiliar words, it's not clear that that's really helpful. Like, what does streptococcal really mean? Or even something that looks like it might be familiar, heart failure. Those are two words that seem like they might be familiar, but in a medical context, they describe a very specific medical situation. They don't mean your heart stopped, which is what it seems like to a patient encountering that for the first time. So that can be a real barrier to people logging on. They see something, it sounds very alarming, or it doesn't really sound like it's meant for the patient. And I think that that's a challenge that in technology development we're continuing to make progress in how to translate some of this stuff so that it's more understandable, or how to make information resources available so that if you're a patient, you find something unfamiliar, you can click through to learn more about what does that actually mean.
Sure. So Kurt, physicians are now sharing medical records, from a patient's perspective, that can be a little bit scary sometimes. You think about, who's seeing my medical records, who has access to them, what's the advantage of it? Why do we have sharing of medical records, and why is that important?
Well, there's so many different providers that are responsible for caring for patients that if we can't share the information, we can't take good care of patients. I think just yesterday I went to a presentation by one of our transplant surgeons, and he mentioned the fact that there's 100 people who are the providers for the single transplant that is that one big surgical event. That's a lot of people to have to get on the same page. Now, transplants are obviously at one extreme of the level of care that we provide, but even in simpler things where we take care of patients in an outpatient environment, there's still maybe dozens of people who are involved in the care of a patient, and many of them may be involved over a very long period of time. So we need to be able to integrate that care, and the digital tools that we have today really have optimized that enormously and allow people that I don't even know are involved in caring for my patients to see the data and vice versa.
Does that work when patients are seen wound up at multiple health systems, they're from out of state and the like?
Well, of course, you see that in the news right now. One of the big initiatives from the federal government is to try to get healthcare centers to share data more, and there are some controversies about that. The standards for sharing data are still very immature. We actually started writing our first standards in the 1980s, and they didn't really begin to mature until the 90s. Most of the standards that we have that are relatively mature, you'll be shocked to know, have to do with getting paid. So the standards for sharing clinical information are really still just emerging. We're pretty good at sharing laboratory data, but when you get into things like terminology, like Jessica was just talking about, even among physicians, we don't have good standards. So it's going to take a while for all that to happen. That being said, we're actually very good at sharing data in bulk. So for example, when I see my patients, I can push a button and I can get access to the Hospital for Special Surgery, to NYU, to Sinai, to Montefiore. In fact, I can get access instantly to pretty much any hospital in the country that's using my brand of medical record, okay, which is hundreds and hundreds of hospitals, but it's not every hospital. So there's still problems, there's still a gap between the way the vendors communicate, and that's where we need standards to really help. And then the specificity of the data so that it's not just a big blob of data, but we actually can tag the data appropriately so that I see only what I need to see and it suppresses the stuff that I don't need to see, because it is too much information at this point for a doctor to process.
So Adam, are these technologies actually, saving the healthcare system money, or are we just contributing to, further rise in healthcare spending, which I think everyone kind of agrees at this point, the country is devoting too much of its spending on healthcare?
So I would say that the promise of these technologies helping to save healthcare costs has not really been realized yet, partly for some of the reasons that Kurt just pointed out. I think as we get better at utilizing the data, being able to predict which patients may be hospitalized or may get sick in the next month or two and need to go to the emergency room, I think that there's the potential for really saving costs there. Certainly, in theory, being able to share records and prevent duplication of care, which definitely happens. As Kurt was mentioning. I mean, I literally saw a patient today who was seen at another institution that also uses Epic, who had a CAT scan. He couldn't remember what it showed. I was able to go out and grab that CAT scan report, read it, and give him some advice, and then not have to either worry about waiting weeks or weeks to try to get a report, or in the worst case scenario, repeating that CAT scan because I couldn't find it, which definitely happens. So I think that's a real potential benefit. And then I think the whole arena of telemedicine, I think, has the potential also to reduce office visits, to allow patients to have video visits with their physicians, which may be less expensive. But it's one of the reasons why insurers and Medicare have not really jumped on the bandwagon to start to pay for those visits, because I do think that they think that there's the potential for overuse and abuse. You could turn every phone call that you would have with a patient into a video visit, which gets paid for, and I think that has the potential to drive up costs. And so I think we have to be judicious about what we think, and again, I think that's why some of this is going to be driven by what the payers decide to do, the insurance companies.
So Deborah, how are we testing, whether these technologies that we're trying to use to keep patients out of the hospital, keep them well, whether they're working?
So I come at this as a, it's working? I come at this as a technologist. I came from things like internet, where internet technologies and mobile applications and those technologies, what does it mean to work? What it means to work is if somebody pays for the service, if somebody downloads your app, if you get lots and lots of people, joining Twitter or Facebook. And that's great, things grow exponentially, but that is not good enough for things having to do with health. It's not good enough that somebody downloads an app or that somebody wears a Fitbit. The question is, how does that actually play into disease management, into prevention and such? And I am a strong believer, there's plenty of understanding about human behavior and physiology to say that there's a really promising role for apps and wearables and data and information from patient to better communicate to clinician their state, to get ahead of problems before they get really bad. And sometimes I think about this as, we hear a lot about genomics and all that's going to happen from that, but that's what you're born with. And a lot of the data that we'll be able to get off of these technologies will sort of fill the gap between what we're born with and what we actually suffer from, which has to do with lots of things that have nothing to do with our genes. And so there's a great potential, but between the potential and something that actually works. How should a clinician use this data when they're treating somebody with migraines or MS or Parkinson's, or helping somebody trying to manage their prediabetes? And the way things are happening now is by great clinician academic clinicians and clinical faculty at Weill and other places who are saying this can change some element of my practice, and they go out and they get research grants and they engage patient communities and they collect data and they do science and generate evidence. And so just a last thing on that, about a year and a half ago, Apple announced something called Research Kit. We're in New York City, so probably a lot of you have smartphones, and a lot of your smartphones are Apple iOS devices. And Apple really said, let's start doing research on how we can see, for example, if you're trying to measure Parkinson's symptoms, how does a tapping test on the surface of your touch screen can that help us measure the state of your symptoms for a Parkinson's patient over time? And so the clinical community around the country is coming out with these applications that that are gathering data from patients. They're evidence engines to generate that evidence so that it can start to be how people get cared for.
So I want to kind of segue into some of the ways that Weill Cornell is actually using technology, some of the solutions they're actually employing. So I'll start with Megan. You've looked into using kind of telemedicine to treat people with post-traumatic stress disorder. So what did that look like, and what were some of the hurdles to getting that started?
Sure. So I was fortunate enough to get a grant to fund me for 2 years to run a pilot project to try to offer care, evidence-based treatment for post-traumatic stress disorder using video conferencing, and have patients never come in at all for an individual visit, do the entire care from start to finish with telehealth, and to even prescribe a medication using only a telehealth visit to have the patient. This was a research trial, so they were taking either a medication or a placebo. It was a double-blind trial. And they were also providing genetics. So we could really try to do a somewhat complicated research design using this distance technology and reach people who could not make it into care otherwise. And we were really able to find that, in fact, one of the questions was a very basic one. Would anybody sign up for this crazy idea? Would people get better? Would people drop out? What would happen with this? And we found that, in fact, people did sign up. This was specifically looking at people with occupations at risk who had post-traumatic stress disorder. So a lot of people who never planned to ever see a therapist, firefighters, police officers, military patients, people who in the line of work encountered trauma. And these are very stoic individuals, if I had to type them as a group, so not somebody who's typically wanting therapy. And maybe doesn't love technology either, but people did very well. They came in for the tele, they didn't have to come in. They enrolled, and people stuck it out and actually had really extraordinary results with their trauma symptoms, with their depression symptoms. We got 100% of our genetic samples back through the mail. We sent out a self-addressed stamped envelope, and people returned them. We had them spit into a cup in front of us and return it. They were all viable. So it really showed that, in fact, this can work as a way to try to do both clinical care in a psychiatric setting and to do some research as well and reach people. A lot of our first responders do not live in Manhattan. They can't possibly afford it, and they travel. When I see them face-to-face, they sometimes are traveling over 2 hours to come in for care. And that's a big burden on you, especially if you're terrified to drive or ride the subway or things like that happen to people after trauma. So it's a great way to expand care.
But in psychiatry, you're trying to develop a relationship. Sometimes that's done. That's done in person. So, how is that different? Trying to establish that relationship, via screen.
I don't know that it's any different, but it was definitely one of our questions was, would people feel connected if there's a screen instead of that you're sitting in front of me? And we looked at that. I looked at that as one of the variables, and in fact, we found there was a strong therapeutic alliance. People did feel connected to the clinician. I use this in my clinical practice as well, outside of research auspices. I'm an anxiety and trauma specialist. And it's just a useful tool. Sometimes people are so symptomatic at the beginning of treatment, and they're avoiding the things that make them anxious or that are associated with their trauma, and have a very hard time coming in for care. So it's really a way to at least get the ball rolling. Because I do cognitive behavioral work, we wouldn't stop there, right? Part of it is having people get out in their life and start to enlarge their life and get back the things that they've been avoiding doing, but it's a great starting point and can really allow us to see people who otherwise might say, I'd love to come in, but there's absolutely no way I could tolerate how anxious that's going to make me. So the relationship is paramount. You just have to make sure you have a really strong connection. You don't want to drop a call in the middle of somebody telling you about the worst thing that's ever happened to them. And you need to make sure it's confidential, right? So I did the work with people often from their homes, and I would just make sure nobody's going to walk in the middle. I don't want you editing what you're telling me because your wife is right there. And occasionally I'd have to ask somebody to take their dog off their lap. But that's a good problem to have, I think, so.
So how is this actually working? I mean, is someone pulling out a phone? Is it, you think about FaceTime on the iPhone, or is it, how are these visits being conducted?
With the research work and when I see people clinically, I prefer a larger screen than an iPhone. I have resorted to FaceTime if I have to. HIPAA compliance is important, so I used a specific technology when I was doing the research study. When I see people clinically, I use a HIPAA compliant portal to make sure that it's confidential and it's not going to be hacked into. And no one has studied this yet, but I hypothesize that at some point, if the image is tiny, I would think that would affect the ability to feel a relationship with the person. I don't know what kind of size we're talking about, at which point it's hard to feel that it's not that much different than a phone call, but I would think there's some threshold at which you might as well just talk on the phone, but I don't know where that is. So I tend to prefer being able to be seen and being able to see the patient and see all the nonverbals that they might not be telling me, oh, I'm sweating and I'm shaking and I have a tear, but I can see that when I'm using video as a way to treat that's much richer of a clinical encounter than just a phone call.
So, G, I know at Lower Manhattan Hospital you're using digital health, for stroke care. So how is the application of digital health different, with acute care when you have a patient in a more serious condition?
Right. So stroke, as you know, is a neurologic emergency, and it's a disease that is treatable but needs to be treated very, very rapidly. And so when you have an artery that's blocked in the brain, you have to treat before permanent damage is done, and that's a very, very small window of time. In order to provide rapid access to all patients who come in with stroke who need treatment, one of the mechanisms we use is telemedicine. That is a very rapid way of evaluating the patient. So the key when someone comes in with a stroke is that you have to assess the patient. You have to determine what type of stroke they have, and that really is dependent on the exam, that there's no CAT scan. You do a CAT scan to eliminate hemorrhage, but once a stroke shows up on a CAT scan, the damage is already done. So you have to make the diagnosis before you have any imaging data, and it's really based on how they look. And with that exam, you also have to go through various criteria for whether they're eligible for treatment. So it really does require a specialist to evaluate the patient, and you have to lay eyes on the patient. And so with telemedicine, you need to provide 24/7 care, and that way, off hours, this device is in the emergency room at all times, and when a patient comes in, when we're at home evaluating the patient, we open up our laptops, we can see the patient, and it's a very high resolution system, so we can see the exam very, very clearly, and that gives us enough information to make the diagnosis. It's a two-way camera, so we talk to the patient or the family members, discuss the risks and benefits of potential treatments, and then if we proceed with treatment, we talk to the emergency department and they give the TPA. So it's rapid access to a specialist who can make some of these very tricky decisions for acute stroke care.
I mean, are you confident in kind of the reliability of that kind of technology when you have a life-threatening situation?
Absolutely, and that's been studied. There have been several trials, both in Europe and in the U.S., San Diego, in the South, as well as upstate New York. So it's been well validated, and it's not just sort of looking at the patient. We actually have a very standardized scale. It's a stroke scale to determine the severity of the deficit, and it's a several-point scale that that's been validated. So telemedicine is not just looking at the patient, but going through a regimented exam.
So, I mean, what are you looking for when you're doing that kind of examination?
So for a stroke, there are many, many different types of stroke, and it can manifest in so many different ways. And that's why you do need a neurologist or a stroke specialist to actually evaluate the patient, because most emergency medicine physicians do not feel comfortable making that diagnosis. So you really have to look at different components of, the vision, slurred speech, facial droop, arm weakness, leg weakness, and a certain pattern of how those symptoms coalesce would suggest a particular artery that's involved and such. And that would lead us to, beyond treating with just TPA, proceed with other sort of more aggressive interventions, which include going into that clot and taking out that artery, the clot in the artery.
And Adam, so New York Presbyterian is now looking to get into employing digital health in the emergency room as well, right? So how's that going to work?
Yeah, so we are definitely doing a bunch of really cool things and innovative things at Weill Cornell and with our partner, New York Presbyterian. One is the telestroke sort of initiative, which is meant to provide that immediate, highly specialized care at some of New York Presbyterian's regional hospitals. So in addition to that, we're doing some televideo visits actually in the emergency room to try to speed up the care that patients are getting. So patients may come to the emergency room, get triaged by a nurse, seen by a PA or a nurse practitioner. And normally in that setting, what would happen is they would then wait for the attending physician who's doing a bunch of other things to round on them and to see them and to review what has happened and then to discharge them. And then they wait for the nurse to come by to do the discharge paperwork and the rest of that. So New York Presbyterian has been piloting a telemedicine project in the emergency room where that visit by the attending and the discharge part is all done by televideo visit. So they're seen by the doctor, they're seen by the nurse practitioner or PA, then they go into a video booth, literally into a room with a video camera, and a physician who's right now on site but could be off site has a visit with that patient, and then literally sort of they're happy, the patient is happy, the patient determines that they're done, they exit the screen and they're literally done and they walk out of the emergency room. So we've been able to reduce ER times from about 2.5 hours down to about 40 minutes. And so far we've done about 200 cases and patients love it. And then the next thing we'll do is so that's for patients who actually show up in the emergency room. And the next thing that we'll be doing is providing urgent care visits face-to-face with our emergency room doctors for patients who are off-site. So you could be at home or somewhere else, and you could literally have a video visit with one of our emergency room physicians. And we're about to start that pilot. And again, obviously this is learning for all of us, right? So we need to make sure that we're only providing this kind of visit to patients who don't literally need to be examined. And I think that there'll be a lot of types of visits which will be amenable to that, but I think it's going to require that we're all careful about how we do that. And then to our other regional hospitals, the telestroke and also the telepsychiatry sort of visits. So again, at regional hospitals, which may not have an on-site psychiatrist, when you have somebody who comes in with a psychiatric emergency, we are actually doing this exact same thing that we're doing with telestroke, which is that you will be able to have a video visit with a psychiatrist in the New York Presbyterian Weill Cornell campus emergency room and provide those services to someone at a regional hospital.
So what kind of things are people coming in to the emergency room with that can be done, over video? I think about suturing or stitches is not really the kind of thing you can do.
Unless you have a robot, correct? Yep. So a lot of it is the kind of things that people go to an urgent care center for. So upper respiratory infections, rashes, potentially sprains and strains and those sort of things that you can at least get the patient to do maneuvers. So I think those are, they tend to be relatively low acuity types of visits that you might be able to handle over the phone, but having that additional video of, show me your throat, show me your rash, show me how you move your shoulder, I think makes a big difference. So I think for the most part right now, it's those sort of visits.
So Kurt, as a physician, do you think that the quality of care, does it go down when you're not, face-to-face with the patient?
Well, that if it is, you're doing it wrong, right? So I think one of the key things to keep in mind with digital technologies is that we're trying to enable physicians and other providers to do things that are not being done today. So if you're going to ask a quality question, you need to ask compared to what? Okay, so if you want to ask, is the quality of looking at a rash over a TV screen the same as looking at a rash in person? Okay, that's one way of looking at it. What's the quality of looking at a rash in front of you or thousands of miles away where you can't possibly do it? Okay, then there's absolutely no comparison because you've enabled somebody to do something that was not possible before. And I think that's really the profound leap that is occurring with digital technologies. So, Deborah runs a program filled with these little geniuses who develop these amazing devices that can do all sorts of measurements in locations that are not possible, notably places like the home. So we can monitor various physiologic parameters at a low cost. We can monitor whether or not an inhaler worked. We can look at pills. We can look at it. There's even monitors from wireless digital injectors that can be used in homes. So that enables us to do things that we couldn't do before. So I have a patient right now who has congestive heart failure. She's what we refer to as a frequent flyer. She comes to the hospital a lot with congestive heart failure, and she now has a monitor in her home. It's very simple. All she does is get on a scale every morning, okay? And with that piece of information that wirelessly connects back to the office, we can see whether or not her weight is climbing. And through that, we've been able to keep her out of the hospital for 9 months, which is a record, okay, by a lot. So that's not something that it sounds like a really simple intervention, but it was not something that we could easily do before until we had all the pieces, the scale, the digital, the wireless, the receiver, the algorithm to notice the change, et cetera.
If I could chime in, and there's just many other medical conditions we've talked about where that applies. So after stroke, recovering from stroke and regaining function, I've heard it referred to as now as a behavioral health issue, because how much can you get yourself to do the physical therapy and the activities you need to do to actually return? And so once again, you aren't going to be able to reach the patient and bring them in as often as the way you can through nudging and engagement and things that you can do by things in the home. Or if we think about in the psychiatric context, having that voice sample from an individual on a daily basis to identify when somebody might be, falling off and entering a phase of depression again, or just noticing that they're not leaving the house anymore and getting to work. These are things that the technologies in an opt-in way can begin to share with the clinician in a way we just could never do before.
So before we get to questions from the audience, I'm going to kind of pass it down the line and see, what each of you think is kind of the one area where you see the most room for kind of improvement in how patients are being cared for and how technology can get that done.
Well, as we spoke about earlier, I've got a particular interest in people with low literacy or less numerical skills, and I would like to make sure that as we're looking at new technologies, that we're making sure that they're really usable by people with less computer skills and that they're really interpretable by people who don't understand medical jargon. So continuing to sort of look at things really from the patient's point of view and not just sort of from this very highly technical language and technical way of presenting things, I think is really going to make sure that a lot of these technologies get out to everybody who could benefit from them.
G?
I think in terms of stroke care, recognition of stroke, as I've mentioned before, stroke can present in so many different ways. What happens when you call 911, for example, is that the 911 dispatcher goes through a set series of questions to determine if you're having signs and symptoms of stroke. And so one day it would be great if we actually had the technology out in the field such that you don't actually need to screen using these verbal cues. You could actually see the patient. So, for example, in the ambulance or even a call from home to 911. If that were all video, it would really make things much simpler in terms of making the diagnosis and getting the patient to the proper hospital.
I think one of the greatest things about digital technologies is also one of its biggest problems, which is that we're producing enormous amounts of data. And we're already at the point that physicians are faced with more data than they can possibly process when caring for a patient. So I think one of the next frontiers has to be automated data analysis, algorithm development, and various forms of analytics so that the computer is actually making filtering out a lot of the noise and only presenting the human analyst with the information that can't be parsed by the machine.
And one of the things I'm most optimistic about, or think is most important, is that we can begin to take the developments that we've done for targeting advertisement and media content and apply that in the same way to help individuals do what they aspire to do, to adhere with the prescriptions and the physical therapy and the other things that they want to do. How can we make the technology that will help us be healthier on a day-to-day basis actually do that?
One of the things that separates the people who are able to use video technology from those who are not is often socioeconomics. So one of the things that we've looked into is trying to have almost a library of iPads with cellular signals so that they could be loaned out to individuals to do a short course of care and then returned and kind of recycled and be able to see people that way, because not everyone has a smartphone or an iPad, and that would be a way to equalize who we're able to serve.
I'm going last, and everybody said all the good things. But so I run our population health and care management programs, and so I guess I would piggyback on what Kurt said, which is I think that all of this data that's coming in addition to sort of being able to filter it for what's important, I think the wearable technology and the home monitoring and that data coming in and actually being able to use that data to intelligently predict who's going to be sick. I think for us, that's one of the biggest challenges, is that you want to try to keep patients healthy and keep them out of the hospital. And we don't really have the parameters or the risk stratification models to actually be able to predict who's likely to have to go to the hospital. And I think as we get the wearables and the technology and the data analytics better, I think we'll be able to actually use all of those algorithms to predict, who we should intervene on sooner, where we should send a nurse to someone's home, a week before they're going to get admitted to the hospital to prevent that. So
I want to turn it over to the audience. I think we have some microphones. Are there? Yeah. Okay.
So my question is why is it that radiology is still giving us the same three-page questionnaire of what surgeries do you have? Have you ever had contrast? When are they going to come into the modern age? It's all right there in the same computer they're putting my results into. So how come they don't have my history?
Yeah. That's a fantastic question, and because I'm a doctor, I'm going to blame the lawyers. So, because there's two problems there. So, one issue is, are we sharing the data, and are they, why are they asking you the same question over and over again? And that's our fault, okay? Which we're actually pretty good at that now of not doing that. But then there's the second question, which is, there's a medical legal issue, which is that there are certain questions that have to be asked 100% of the time. So every time, and this is very frustrating to patients, particularly in an academic medical center where you're seen by the medical student, the intern, the resident, the attending, the cardiologist, the pulmonologist, and they ask the same question.
Radiology. When I'm going in for my CAT scan or my MRI, why can't they just print out my answer from the last time and have me initial?
Because they have to make it, well, so that is in fact what where we're going, is more and more getting you to validate the data that you did before. So we now have these face sheets. I don't know that they're using in every radiology department, but we've got them in most, where you do actually validate that information.
Yeah, so I'll also answer that question and just say that we'll talk to the chair of radiology, because he's very interested in technology and in actually patient satisfaction and services. And I think the truth is, a lot of this is just we're just not keeping a good enough eye on this. I think it's definitely true that there are a lot of situations where we're making people fill out the same forms because that's what we've always done, and because there's no question that so much of that should either be digitized, so you get an iPad when you go into the waiting room, and these are, do you still have all of these? Are you still on these medications? Yes, but.
I can just as easily print it out from
Yep.
the net and say, instead of my having to hand write down 10 surgeries, why can't I just print it out at the
Yep.
net and say, here it is?
Yeah, no question about it, and it's a great question, and in a lot of cases, there's not a really good reason for that stuff.
Thank you.
Right there in the ER. Yep.
So my name is Peter Frischau. I've spent most of my life pushing healthcare information out to both professional clinicians as well as consumer audiences, or to paraphrase what Deborah just said, using technology for online media to target people with both information and advertising. So, and I'm best known as the founder of Netscape back in 1995, which until about 10 years ago was the most widely accessed site by clinicians for medical information, until an even more popular site came along that both medical professionals and consumers use. Can anybody think of what that might be?
Google.
Wikipedia.
Google, Wikipedia. It's actually Wikipedia, which has incredibly valuable and good medical information, much of it curated by clinicians and medical students now, and it's really, really good. So but people like Deborah, who have also championed something called Open Health, which is really, really important for encouraging the exchange of information, and many others are making great progress. But still, medical institutions are a good 10 or 15 years behind the general public in terms of how they actually use internet technology. And I think one of the reasons why it's getting better is that people who work in these institutions are also consumers and are so incredibly frustrated by the abysmally horrible software that they're forced to use, that they're saying, hey, I can get all this information on the web, and yet I'm in the hospital and I can't get it. What's wrong here? And gradually now we are beginning to see progress.
Did you have a question?
I do. A couple of things. The patient portal is great, but it really shouldn't be characterized as giving patients access to their medical record, because it doesn't. The medical record and what patients have on patient portals that I've seen are really not the same. So if I'm wrong about that at Cornell, I'd like to know that, but in my experience, they all have been quite different. And usually they don't include images that you can, for example, forward to another clinician. So that too is another question. Is the technology that you are making available to patients at Cornell that nicely interoperable that they can actually forward those tests and results and images to people who are outside of your
So you've brought up a wide variety of different questions here. So one of your questions was whether the portal showed your medical record, and then you brought up another question, which was whether patients could use this to transfer their medical record to another institution. So those are...
Yeah, any other expert that they want.
So the electronic patient portal shows a subset of routinely shows a subset of what's in your medical record. You always have the option of requesting the full record should you wish it. The subset of stuff that appears in the patient portal is usually the things that patients are actually more interested in looking at more often, like their medications or their laboratory results. So that's sort of one of your questions. The other question is, can it be gotten out of the portal and sent somewhere else? And the answer is yes. All of the portals have a number of different export capabilities. Blue Button is the one that we use at Cornell and NYP. There are other options there that allow you to export in a couple of different formats depending on what purpose you're planning to use it for.
Images too?
The images currently are separate. Images are stored in a different system than the rest of the medical record because they're very, very, very much larger than the actual medical records themselves. Actually, imaging is one of the areas where we actually have very good standards for data exchange. So the radiology department does actually support an export function, but currently it's generally done from site to site, or actually most patients are actually given a DVD of their images.
That's great.
So.
Thank you.
We're sitting here 7 years from now. We hit not a home run, but a triple. Insurers are involved. The computer people have gotten involved. What is your life like in terms of your work life? How does it work for you? What is the significance to us as consumers? And what's the hospital like? Do we have one?
Did you say 7 or 70?
7.
So
Why 7?
I'll answer a couple. I'll answer a couple of those, and then I'll let others. I mean, I think for on the clinician side, I hope that the use of electronic health records is a lot easier for us, and therefore makes our interaction with patients feel much more personal and much less like we're just typing on a computer in front of you. I think it's very variable based on based on a physician's skill at typing and being able to actually keep that that face-to-face interaction. So I hope 7 years from now that will actually be a lot better. I'll answer your next question, which is we will definitely have hospitals, and I think they will look very similar to what they look like now. 7 years from now, maybe 15 or 20 less. But I'll let somebody else.
Yeah, I think one of the things that's important to keep in mind is the standards that we have in healthcare for adopting new technologies are very high for a very good reason. All right, so all right, I know many of you in the audience may be old enough to know what this is. Okay, it's my favorite prop. This is a beeper. Okay. No one of us, under probably the age of 30 even knows what these are, and yet we still use them in hospitals. And the reason we use them in hospitals is because they are bulletproof reliable, and cell phones are not. You can't reliably send a text message and know it's actually going to get delivered. Now, we are actually in the process of putting in literally millions of dollars worth of antennas so that the cell phones will work reliably in the hospital. But that's a huge expenditure that you don't even think about in consumer technology because if Verizon drops your call, you make fun of them, but nobody dies, right? So we do have standards that are very high. And so that does slow the adoption curve. But not necessarily in a bad way. So it means that certain ridiculous technologies don't actually ever even enter the fold. So that's why I think 7 years is, things will be very different in 7 years. Hopefully the beeper will be gone. All right. But a lot of things that we're using today will just be incrementally better, not profoundly transformed.
Back there.
Who's paying for all this stuff? I like the patient who is at home sitting on her scale, hooked up to monitors, that get trained. I mean, who pays for this?
So that one is a great example of really saving money. Okay, so every time she gets admitted to the hospital, it's $10,000 or $20,000 minimally, and that's if she didn't end up in the ICU, which she often did. So spending, even if that scale costs $1,000, which it doesn't, but with all of its apparatus and getting it set up, that's nothing as long as you can keep her out of the hospital. So, so for that, an insurance company will definitely pay.
Right, but that is some of the sort of catch-22 right now, which is often in those sort of settings, it saves the insurance company money, but it costs the patient and or the health system money to introduce that technology, and there isn't an immediate return. So I think there's a lot of sort of payment reform going on in healthcare, so that there is that potential to recoup those dollars or share those savings. If you prevent a $20,000 admission right now, United Healthcare saves $20,000. So there's a lot of that going on, and we're not there right now. So I think that is a important question.
Yeah, Adam, I'm just curious about the digital ER. At this point, insurance is not covering it, right? So is that, I mean, are patients being asked to pay for it out of pocket?
Right.
Or?
So some of it. So the actual digital ER visit, where the patient actually comes to the emergency room and then has that face-to-face visit, is paid for by insurance, just like a regular emergency room visit, because the patient is seen by a nurse practitioner or a PA. But the virtual visit, when the patient is at home, that's right. It is not paid for by most insurances, as are most telemedicine visits now not paid for by insurance. So that's a self-pay. Correct. So again, it depends. Some insurance companies or employers have contracted with off-site telemedicine vendors to supply that visit because they think it's less expensive than you going to your doctor, so they're willing to give you a visit, but they're not willing to pay your doctor for the visit right now, at least in most cases.
That might change in 7
Correct.
years.
I think that's probably, that probably will change in 7 years. Correct. Not yet. And again, it's very different. I won't say that that's true across, but Aetna has thousands of employers, and each employer may have a different relationship with Aetna and a different plan. So some employers might pay and some might not. So it's a lot of complicated contracting work to try to figure that out. I think ultimately they will pay, but visiting a teledoc doctor who's in Iowa in a room with lots of other people doing this may be a lot cheaper than doing a teledoc visit with a doctor at, in New York, at your doctor at Weill Cornell. And so, again, that is a pain point for everyone.
Yeah, I have a question and picking up on the role of the public libraries and access to information for non-emergency conditions for people who may not have full literacy, people who do not speak English proficiently. And so do public libraries have a role in being the hub of the communities where they don't have access to computers and language skills? And will we get to a point where Google Translate can actually get to a point where they can actually translate the things that are being sent to them?
I'm so happy you asked that question. Yes. So we so undervalue our libraries in this country and what they are able to do. Our library at Weill Cornell actually runs a patient resource center that is staffed by a clinical librarian
For free.
For free, and her job is to help patients sort out the garbage that's on the internet and actually find accurate healthcare information. And we do things like the free iPad programs and things like that to try to actually really help patients engage in health literacy. But there is a big problem, which is libraries are really suffering because there is this weird thing happening where people think they are obsolete when they're totally not. So they're not getting funded. And there also is a shortage of clinical librarians in the United States.
But I thought at one stage we thought libraries were going to be dead buildings.
Yeah, and they're so not.
No,
They're very
they're completely
lively
crowded.
places.
And,
And
yeah.
how can we create a situation where public libraries are funded so that they can play this very critical role?
And the second part of your question about Google Translate, ultimately more and more of that, but in the meantime, you can also, and I know that there are some startups in this space, that you can connect to somebody who speaks your language. The internet connects us all, so simply keeping the human in the loop, but being able to get to that right human is something that's starting to happen.
Question in the back there.
Yeah, good evening. So actually two questions. My first question was to what extent does Cornell embrace blockchain in evolving developments? And secondly, also, as we're moving into more and more into an e-connected environment, to what extent is there the threat of being exposed to more electromagnetic radiation?
Do you handle this blockchain thing?
Well, I can't speak for I cannot speak for Weill Cornell in terms of whether they are embracing
We're not.
Blockchain. I can tell you that there are some real experts in cybersecurity and blockchain technologies who are exploring a broad range of applications of the technology at Cornell Tech. In fact, we have one of the world's experts, Ari Juhl. So check out the Cornell Tech website if you have an interest in the technology, but I can't speak for Weill.
Yeah, so it's not in clinical use today, but there's a lot of people, but that's exactly, we look to the engineering, the people who are inventing the generation and the generation after that. They're the ones who are going to figure out how to use that technology. I think it's very promising, but it's not in clinical application today.
Deborah, blockchain, and for those of us who aren't
what
familiar,
is
is
it?
there a 5-second
It's the technology that's behind cybercurrency, and the whole idea is that you, instead of having to have a centralized bank, that you have a technology that allows you to store information in a very decentralized way.
Question there in the back.
Yes, I'd like to know about the sharing of information and HIPAA violations. Is anyone of you concerned about HIPAA, transmitting data with the patient's privacy? And to the gentleman to my right with the VA, I'm a VA. I went to the VA today, and I could look at the VA. I could look at my health records on the VA with their system, the Florida system. Okay. This is about HIPAA violations.
Yeah, so obviously, for those of you who don't know, HIPAA is the Health Information Portability and Accountability Act of 1997, which is what set the initial privacy rules for healthcare in the United States, and then it was updated a few years ago. So we are a HIPAA-covered entity, so everything that we do is in the digital space is regulated by HIPAA, except those things which are not. So HIPAA has huge exemptions in it. So basically, payment, for example, is outside of HIPAA. So so there's a lot of data that moves around in the United States that is healthcare data that's actually not covered by HIPAA. And some of that data is the data that has been most subject to compromise. Security and privacy are a huge issue for us, and we spend an enormous amount of time protecting data. Healthcare providers are a big target for attackers because it's easier to pretend to be somebody else if you know their medical record than if you don't. So you can, the health records are worth more money on the black market. So we're very, very concerned with it. Yeah. So, but.
Even like the software, like email. For example, if you were to send me, let's say if I was a doctor, you were to send me, let's say, information as a file attachment. That would be.
That would not be.
Okay, but then I can go back. I can forward that information to you with that file attachment. I wouldn't be in a violation with you, but I'd be in a violation with him because I filed that file attachment.
Yeah.
Too.
No, well, as the patient, you can do whatever a patient could
do whatever
release
they
their
want.
own information.
Yeah.
The HIPAA prevents us from releasing information.
Let's say like a nurse or something like that. Though. Let's say if I was a nurse and I got information, let's say from another nurse, and then I had a file attachment which is HIPAA related, but then I forwarded it to somebody else.
Yeah, which they,
Right,
yeah. So that's one of the reasons we have the patient portal is that way those information exchanges stay within the portal and are not using email.
So I think I'm going to turn it over to 92nd Street Y at this point.
Okay, we can have time for one more question.
He's been waiting.
The issue of office visits for a physical. Under your new system, it would seem that this would not happen, and the relationship between the patient and the doctor may not be as good.
Right.
Now, I'm concerned the psychological implications of this between patient and doctor.
Right. So, so what I would say is anywhere, any sort of visit where you're using the word physical, I think realistically can't involve telemedicine, because if we need to lay hands and examine someone, obviously that you can't use a virtual visit for that. I think a lot of people have argued that you should not, that a televideo visit, when you have never met the patient and you've never examined the patient directly, should not be allowed, that you have to have a direct relationship with a patient and a physician before you should be allowed to have a televideo visit. So there have been some regulations around that. Some people argue for it, some against it. But in that setting, we would never force a patient to take a televideo visit instead of an in-person visit. We would see this as an add-on and as a potential benefit if you can't travel or you're actually out of the state and need to have a visit with your physician. Now that physician may say, look, I can't make a determination about that. You actually need to be seen and examined. So I agree with you. I think that part of what makes medicine special and part of what makes the patient-physician relationship special is that direct contact. So I don't think it could ever replace most of the patient contact, partly because a lot of what we do really requires us to touch you and examine you, and also because I think the relationship setting is an important part of physician-patient relationships. So.
I'm sorry, this gentleman right here, we're waiting a long time. Just one question.
Oh, thanks. Just wanted to know about so towards the end of your closing remarks, you mentioned about the sheer amount of data that's there. So how about the other, the forefront of computer science, like machine learning and those sorts of things? So when are we going to have maybe some automated diagnostics or even treatment recommendations? How close are we to that?
Actually, the very first computer application in healthcare was in the 1950s, and it was a diagnostic system called the Cornell Medical Index. It was 100 questions that were punched in using IBM cards, and then the computer spat out a diagnosis. It wasn't very good, but it was 1950. So we've had expert systems for a long time. So actually, computers in certain fields are incredibly good at doing certain kinds of analytics. So very good at, for example, recommending which antibiotic to give in a complex scenario, how to wean a patient off of a respirator. There are certain things where we've developed these algorithms. The problem has been getting the data into the computer. Okay, so, and that has to do with the standard, has to do with data acquisition devices, and a lot of other complicated problems. But the answer is it's happening now. So that we are already starting to see that shift occur very much in real time. So.
Okay. Now I think that that's the end of our question and answer period. Thank you so much for participating. And please help me thank all of the panelists on our stage. And thank you again to Weill Cornell Medicine for sponsoring this event. Thanks. Good evening.